When we are in love, heartbroken, sad, and happy, we often correlate these strong emotions to the heart, or often we associate the heart with emotions. But it is crucial to note that emotions are a result of brain function and not the heart. The heart, in fact, is a muscular organ that is essential for life as it pumps blood throughout the body in order for it to function. Good day, everyone. I, Andrea Nicole Cadavos, together with Cyril Alexi Gerardino, Elijah Alexandre Cabrijas, Atea Kate Antolino, and Jillian Mendoza will discuss all about Chapter 12, The Heart. So we are going to discuss functions of the heart, size, form, and location of the heart, its anatomy, histology, stimulation action potential of the heart, cardiac cycle, heart sounds, and the regulation of heart function. Let us begin with the functions of the heart. So the heart is a muscular organ vital for life as it pumps blood throughout the body. Similar to a pump forcing the water through a pipe, the heart contracts to propel blood through blood vessels. The heart, blood vessels, and blood collectively form the cardiovascular system. At rest, a healthy adult heart pumps around 5 liters of blood per minute and pumps at approximately the rate for more than 75 years. While being a single structure, the heart functions as two pumps. So the right side pumps blood to the lungs, which we call pulmonary circulation, and the left side pumps the blood to the rest of the body, which is called the systematic circulation or the systemic circulation. So the major functions of the heart includes, first one is the generating blood pressure. So the heart contracts to create blood pressure, which forces the blood through the vessels. Next is routing blood. So the heart separates the pulmonary and systemic circulations, which ensures tissues to receive adequate oxygenated blood. Next is ensuring one-way blood flow. So the heart valves guarantee an unidirectional flow of blood through the heart and vessels. And the last one is it regulates blood supply. So heart contractions adapt to changing metabolic needs, matching blood flow during rest, exercise, and changes in body composition. Next, we will discuss the size, form, location of the heart. So let us begin with the size and shape of the heart. So the adult heart resembles a blunt cone and is about the size of a closed fist. Its size may vary in physically active adults compared to less active adults. So the apex is the blunt rounded point, while the base is the larger flat part, as we can see in the picture. Next is its location in the thoracic cavity. So it is positioned in the thoracic cavity between two pleural cavities which surrounds the lungs. It forms the mediastinum, which is a midline partition along the trachea, esophagus, and associated structures. The heart has its own cavity, which is called the pericardial cavity. Next is the orientation in the thoracic cavity. So the heart lies obliquely in the mediastinum. The apex points anteriorly, slightly inferiorly to the left. It is about 2/3 of the heart's mass is to the left and the midline of the sternum. The base is behind the sternum, which extends to the second intercostal space. The apex is behind the fifth and sixth ribs at the fifth intercostal space and to the left of the sternum. And the mid-clavicular line is a useful reference. It passes over the apex when drawn down from the middle of the left clavicle.
So now we are going to discuss the anatomy of the heart. So first, we are going to discuss the pericardium. The pericardial cavity is formed by the pericardium or the pericardial sac, which surrounds the heart and anchors it within the mediastinum. So the pericardium consists of two layers. First is the fibrous pericardium, and next is the serous pericardium. The fibrous pericardium is the outer layer of the pericardium and is composed of tough, fibrous connective tissue. For the serous pericardium, it is the inner layer and consists of the flat epithelial cells with a thin layer of connective tissue. So there are two parts of the serous pericardium, which is the parietal pericardium and the visceral pericardium. The parietal pericardium lines the fibrous pericardium, while the visceral pericardium covers the heart surface. The parietal and visceral pericardia are continuous with each other where the great vessels enters or leave the heart. The pericardial cavity is located between the visceral and the parietal pericardia. It is filled with a thin layer of pericardial fluid produced by the serous pericardium. The pericardial fluid now helps to reduce the friction of the heart, which moves within the pericardium. For the external anatomy, we have the right and left atria, which is located at the base of the heart, the right and left ventricle, wherein it extends from the base of the heart towards the apex. Now, the coronary sulcus extends around the heart, separating the atria from the ventricles. We have the anterior interventricular sulcus, which is on the anterior surface of the heart, posterior interventricular sulcus, which is the posterior surface of the heart. Now, the blood first enters the heart of the atria. The veins carry the blood to the atria. Now, the superior vena cava and the inferior vena cava carry the blood from the body to the right atrium. And the four pulmonary veins carry the blood from the lungs to the left atrium. So the blood exits the heart at the ventricles, and the blood flows from the ventricles through the large arteries, often called the great vessels or the great arteries. The pulmonary trunk arising from the right ventricle splits into the right and left pulmonary arteries, which carries the blood to the lungs. And lastly, the aorta arising from the left ventricle carries the blood in the rest of the body. For the heart chambers, we have the right atrium, left atrium, right ventricle, and the left ventricle. So the right atrium receives the blood in low oxygen from the body and then empties the blood into the right ventricle. The left atrium receives the blood full of oxygen from the lungs and then empties the blood into the left ventricle. The right ventricle naman pumps blood low in oxygen to the lungs and in the lungs, the blood then gets a refill of an oxygen. And lastly, the left ventricle pumps the blood full of oxygen out of the body.
Now let's delve into the heart valves. The one-way flow of blood through the heart chambers is maintained by the heart valves. There are two types of heart valves, the atrioventricular valves and the semilunar valves. First, the atrioventricular valve is located between each atrium and ventricle. The AV valve between the right atrium and the right ventricle is called tricuspid valve because it is composed of three cusps of flaps of tissues. The AV valve between the left atrium and the left ventricle is called the bicuspid valve because it is composed of two cups. The bicuspid valve is also called the mitral valve. These valves allow blood to flow from the atria into the ventricles, but prevent it from flowing back into the atria. When the atria forces the AV valves to open, and blood flows from the atria into the ventricles. Next, please. In contrast, when the ventricles contract, blood flows toward the atria and thus the AV valve close. Each ventricle contains cone-shaped muscular pillars called pillary muscles. These muscles are attached by thin, strong connective tissue strings called chordae tendinea to the free margins of the cusps of the atrioventricular valves. When the ventricles contract, the muscles contract and prevent the valves from opening into the atria by pulling on the chordae tendineae attached to the valve cusps. The semilunar valve. It is located between each ventricle and its associated great artery. The pulmonary semilunar valve is located between the right ventricle and the pulmonary trunk. The aortic semilunar valve is located between the left ventricle and aorta. A plate of connective tissue, sometimes called the cardiac skeleton or fibrous skeleton, consists mainly of fibrous rings that surround the atrioventricular and semilunar valves and give them solid support. This connective tissue plate also serves as electrical insulation between the atria and the ventricles and provides a rigid attachment site for cardiac muscle.
So before I'm going to introduce to you the route of the blood flow, I'm going to review the anatomy of the heart. So here on the right side, the right atrium, then the tricuspid valve, then followed by the right ventricle, then through the pulmonary semilunar valve going to the pulmonary trunk, then it will branches out to the right and left pulmonary arteries. Then it will go through the lungs. Then from lungs, it will go to the pulmonary veins, then to the left atrium, bicuspid valve, and left ventricle. So the route of blood flow, this concept is important when considering electrical activity, pressure changes, and heart sounds that we'll discuss later on. So the step one of the blood flow is that the oxygenated blood flows through the inferior and superior vena cava into the right atrium, and also from the heart muscle through the coronary sinus. The blood or the deoxygenated blood that flows from the right atrium enters the relaxed right ventricle through the tricuspid valve. In order for this to happen, the right atrium will contract so that enough blood or the pressure will let the blood enter the right ventricle. So the step 3 is that following the right atrial contraction, the right ventricle will begin to contract. So the contraction of the right ventricle will allow the blood to push against the tricuspid valve and it will force it to close. Then the pressure from the contraction will also force the semilunar valve to open and the oxygenated blood will flow right into the pulmonary trunk. So as the right ventricle relaxes, the pressure will decrease and the pressure in the pulmonary trunk will increase and the backflow of the blood forces the pulmonary semilunar valve to close. Next is the step 4. This is where the pulmonary trunk branches to form the right and left pulmonary arteries. So this is where the gas exchanges happen in the capillaries of the lungs, where oxygen is picked up and carbon dioxide is released to be exhaled. During inhalation, the blood is replenished and becomes rich with fresh oxygen. The blood will become bright red. So this is the process of from the oxygenated blood, it will convert to oxygenated blood. Next is step 5. The oxygenated blood. So from the lungs, it will flow to the 4 pulmonary veins and into the left atrium. Next is step 6. Oxygenated blood from the left atrium will pass through the bicuspid valve and into the relaxed left ventricle. So the left atrium will contract again and will push blood into the left ventricle and it will complete the left ventricular filling. On the step 7, the left ventricle will begin to contract, and this contraction will push the blood against the bicuspid valve, and also it will force it to close. So the pressure from the contraction will force the aortic semilunar valve to open and allow blood to flow into the aorta. So ang aorta, this is the one that carries oxygen-rich blood away from the heart to the smaller arteries. And the last step is that the distribution of oxygenated blood. So from the aorta, the blood will be distributed to all parts of the body except to the parts of the lungs supplied by the pulmonary blood vessels. So as the left ventricle will relax, the pressure will decrease and the pressure in the aorta will increase. So the backflow of blood forces the aortic semilunar valve to close. So the oxygenated blood will flow to the all parts of our body, and the blood, having given up its oxygen and taken in carbon dioxide from the body's organs and tissues, then it will return again to the heart through the veins. So meaning galiwat-liwat lang ang cycle. And also the circulatory system or the blood flow is only one way. So hindi siya pwede maging or hindi siya pwede mag-reverse. So, muna ni siya ang summary of the route of blood flow. So, from superior vena cava, inferior vena cava, makakadto siya sa right atrium to the tricuspid valve, then to the right ventricle, dayon pulmonary semilunar valve, pulmonary trunk, and pulmonary arteries. So, these are all the oxygenated blood. Then, it will go through the lungs, and this is where the gas exchange. And from the oxygenated, maging oxygenated na siya if magkadto siya sa pulmonary veins. And then, same process, go to the aorta. Pag-abot siya sa arteries, ma-disseminate na ang blood in the different parts of the body, kag maluwat naman ang cycle. Mabalik naman siya sa superior and inferior vena cava. So blood from the area of the head and the neck travels to the heart through the superior vena cava. And the blood from the abdomen and the lower parts of the body flows back through the inferior vena cava. So after delivering oxygen to tissues and absorbing waste such as carbon dioxide, systemic circulation brings the oxygen-poor blood to the heart, specifically to the right atrium. So the heart consists of heart wall and the cardiac muscle cells. So the heart wall is composed of 3 layers of tissue: the epicardium, myocardium, and the endocardium. So the function of heart wall is to pump blood efficiently, support the circulatory system, ensure the delivery of oxygen and nutrients to the body's tissues, and remove waste products. So the first layer of tissue, which is the epicardium, this is the outermost layer. As you can see in the diagram, it is also called the visceral pericardium. It is a thin serous membrane forming the smooth outer surface of the heart. It is the inner layer of the serous pericardium. It consists of simple squamous epithelium overlying a layer of loose connective tissues and adipose tissues that serve as an additional layer of protection from trauma or friction for the heart under the pericardium. So this layer contains the coronary blood vessels which oxygenated the tissue of the heart with a blood supply from the coronary arteries. So next is the myocardium, which is the middle layer. It is a thick middle layer of the heart composed of cardiac muscle cells or cardiomyocytes. So cardiomyocytes are specialized muscle cells that contract like other muscle cells, like skeletal muscles, and have a fewer nuclei, and it is also striated. It is responsible for the contraction of the heart chambers.
So this require a dedicated blood supply to deliver oxygen and nutrients and remove waste products such as carbon dioxide from the cardiac muscles tissue. This blood supply is provided by the coronary arteries. So the last one is the innermost layer, which is the endocardium. It is the smooth inner surface of the heart, which consists of simple squamous epithelium over a layer of connective tissue. It allows the blood to move easily through the heart since it is a smooth inner surface. It also regulates metabolic waste removal from the heart tissue and act as a barrier between the blood and the heart muscle. So this covers the heart valves. So the heart valves are formed by folds of endocardium that includes a thick layer of connective tissue. So the surface of the interior walls of the ventricles are modified by ridges and columns of cardiac muscle called trabeculae carneae. So smaller muscular ridges are also present in the portions of the atria. So to summarize, the epicardium is the outer layer that contains blood vessels. The myocardium is the middle layer that is composed of contractile tissues, and the endocardium is the innermost layer, and it composes the valves, inner lining of the chambers, and contains vessels and nerves. So cardiac muscle cells are the elongated branching cells that contain one or maybe two centrally located nuclei. So the cells are joined to one another by intercalated discs. So this allow action potentials to pass from one cardiac muscle cells to the next. So the membranes of the intercalated disc are highly folded. So the adjacent cells fits together, greatly increasing the contact between them and preventing cells from pulling apart. So the gap junctions are specialized cell membrane structures in the intercalated disc that allow cytoplasm to flow freely between cells. So, but it contains actin and myosin myofilaments organized to form sarcomeres, which are then joined end to end to form myofibrils. So the actin and myosin myofilaments are responsible for muscle contraction, and their organization gives cardiac muscle a striated appearance. So cardiac muscle relies calcium cardiac muscles relies on calcium ions and ATP for contraction. So calcium ions enter cardiac muscle cells in response to action potentials and activate the process of contraction. Cardiac muscle cells have many mitochondria, which produce ATP at a rate rapid enough to sustain the normal energy requirements of cardiac muscles, and ATP production occurs primarily in mitochondria and depends on the oxygen availability. An extensive capillary network provides adequate oxygen to the cardiac muscle cells, but however, cardiac muscles cannot develop a significant oxygen deficit, and the development of a large oxygen deficit could result in muscular fatigue and cessation of cardiac muscle contraction. And when cardiac muscle cells are organized into spiral bundles or sheets, so the contraction of the cardiac muscle cells produces forces and shortening in these bands of muscles, which then decreases the heart chamber size and the consequent ejection of the blood into the pulmonary and systemic vessels.
Okay. So the muscle in the wall of the heart is thick and metabolically active, thus requires an ample blood amount to supply this. There are two pathways for blood to supply our heart. First is the coronary artery, which are divided into two parts. which is the left coronary artery and the right coronary artery. The second is the cardiac veins that will be discussed later on. So coronary artery is the one that supplies the blood to the wall of the heart, located from the base of the aorta. One of its division is the left coronary artery, of course, originates on the left side of the aorta that has three major branches: the anterior interventricular artery, the circumflex artery, and the left marginal artery. The next one is the right coronary artery. Originates on the right side of the aorta, extends around the coronary sulcus on the right to the posterior surface of the heart. Two of its major branches is the posterior interventricular artery and the right marginal artery. Right coronary artery and left coronary artery and its branches supplies most of the wall of both the left ventricle, if it's left coronary artery, and right coronary artery supplies most of the wall to the right ventricle. Okay, so we have idea that one of the function of the blood is to supply or to transport oxygen. The question is that, does the blood releases equal amount of oxygen all the time or in any instances? We'll see. Okay, so during resting, when you're at rest, for example, you're sitting there and listening to this discussion, your coronary artery has been supplied for 70% of blood oxygen. And however, in the skeletal artery, it gives up only, or the blood in skeletal artery gives up only about 25% of its oxygen. Now, how about if you decide to get up and do some exercises? The blood oxygen released in your coronary arteries cannot increase substantially. So, for example, during resting, when you're at rest, 70% of oxygen ang na-release sa imo, that will stick sa 70%. It's either mastela na siya or manubo. However, sa skeletal arteries, the percentage of oxygen that the blood releases increases to 70% or more. So for example, during nag-exercise ka, mas damo ang oxygen na nag-release sa imong skeletal muscle. Now, we remember that in chapter 7, muscular system, when we exercise, now when our muscle work harder, our body, our muscles uses more oxygen, right? Then our heart beats faster in order for this to supply, or in order to pump the blood that can be delivered pakadto sa skeletal muscle or any tissues nga naga-obra. So that is why nga during exercise, wala nag-increase pagid ang imo nga oxygen level sa imo nga heart. It's because the blood or the heart pumps its blood pakadto sa skeletal muscle. Kag dira iya ihatag ang blood which carry the oxygen. So therefore, the rate of blood flow through the coronary arteries must increase above its resting level. So dapat during at rest ka pa lang, may at least na-increase mo na ang imo nga blood flow to provide your cardiac muscle with adequate oxygen during mag-exercise ka na. The rate of blood flow, okay, this is because the rate of blood flow when your heart contracts, the blood vessels of the coronary circulation are compressed, nag-constrict. Thus, gina-reduce nyo ni ang capability nga mag-flow sa dira nga vessels pakadto sa imong heart. Together. Okay. So when the heart, as a consequence, the blood flow into the coronary circulation is greatest while your ventricles is at rest or relaxed. So the second pathway is the cardiac veins. Cardiac veins is responsible for draining blood from your cardiac muscle. So pathways are nearly parallel to the coronary arteries. Kung makita ta earlier, though if masala ka if wala sang headlines, wala sang guide, kay it's because ang pathways ng coronary artery, the coronary veins is quite parallel and similar. The coronary sinus is most of the blood drained into this sinus. Coronary sinus is a large vein located within the coronary sulcus on the posterior aspect of the heart. Blood flows from the coronary sinus into the right atrium, but some small cardiac veins drains directly into the right atrium. Okay. So like action potential in skeletal muscles and neurons, cardiac muscles also exhibits electrical activity. Action potential in cardiac muscle consists of a depolarization phase, followed by a period of slow repolarization called the plateau phase. At the end of this phase, a rapid repolarization phase takes place and refractory period would end. The cardiac muscle has a period of slow repolarization. Amo lang na ang kinaiba niya sa skeletal kag sa neuron. This greatly prolongs the action potential in cardiac muscle. Action potentials in cardiac muscle can spread from one cell to adjacent cells through gap junctions at intercalated discs. Okay, so process is that depolarization phase, plateau phase, repolarization phase, and refractory period effect on tension. To review, depolarization phase is when there is an increase of positive charge within the cell. So here, the opening of voltage-gated sodium channels and the sodium ion diffuse into the cell that cause the depolarization. The sodium entry, once the sodium enters the cell, it triggers the opening of voltage-gated calcium ion channels. And these calcium ion channels, or calcium ions rather, begins diffusing into the cell, causing this to have an overall depolarization. The next phase is the plateau phase. Sodium channel closes, a small number of potassium ion channels open. However, the calcium ion channels remain open. So this causes the counteract, kung naga-counteract ang potassium sa pagwa sa cell, kag ang calcium pasulod sa cell. Kumbaga gabungguan na yun sila nga duwa, kay iba ang ilang concentration gradient. This causes the slow diffusion of the calcium ion. And that slow diffusion of a calcium ion into the cell is the reason why the cardiac muscle fiber action potential lasts longer. The next phase, or the third phase, is the repolarization phase. On the other hand, repolarization phase is there when there is an increase of negative charges within the cell. So this is where the calcium ion channels closes and many potassium channels open, that allowing the potassium to move out of the cell freely. And the last one, or where the phase will end, is the refractory period effect on tension. It is simply the cardiac muscles contract and relax almost completely before another action potential can be produced. So this is the photo that summarizes the action potential in cardiac muscle, as well as the anong kiniibaya sa skeletal muscle contraction. So depolarization phase, plateau phase, repolarization phase, and refractory period affecting tension. Ang kinaiba lang ginilang ang duwa is wala sang plateau phase ang skeletal muscles.
So next, we will discuss the conduction system of the heart. So let us start with the unique cardiac muscle characteristics. So unlike skeletal muscles, cardiac muscles can contract without neural stimulation. The heart's conduction system formed by the specialized cardiac muscle cells coordinates atrial and ventricular contractions. Next is the components of the conduction system. So the first one is the sinoatrial node, or the SA. It is the heart's pacemaker. It initiates contractions in the right atrium. So drugs like calcium channel blockers can influence heart rate by affecting the SA node. The conduction system includes the atrioventricular, or the AV node, the AV bundle, bundle branches, and Purkinje fibers. Next is the pathway of action potentials. So SA node generates action potentials, which causes atrial contraction. Action potentials which the AV node slow down to allow atrial contraction completion. Now, the AV bundle divides into the left and right branches. It carries action potentials to the ventricles. And the Purkinje fibers ensure rapid delivery of action potentials to all ventricular muscle. Next, we will discuss the cardiac contraction coordination. So the organization of the conduction system, especially the Purkinje fibers, ensures coordinated ventricular contractions. Ventricular contraction starts at the apex, pushing the blood upward toward the great vessels. Next, the heart's pacemaker. So as I've said before, the sinoatrial node is the primary pacemaker of the heart and initiates the heart's rhythmic cycle. Other areas like the AV node can take over if the SA node malfunctions, which results in a lower and slower heart rate. Next is ectopic beats. Originating outside the SA node may lead to fibrillation, which is a dangerous condition. Next, fibrillation and defibrillation. Fibrillation causes rapid independent contractions in small heart portions and reducing blood output. Defibrillation involves a strong electrical shock to restore normal cardiac rhythm. It synchronizes depolarization, allowing the SA node to regain control and reestablish a regular heart rhythm. Next, let us discuss the electrocardiogram. So what is an ECG? So an electrocardiogram, or an ECG, is a record of electrical currents produced by action potentials in the heart during cardiac cycle. Learning about the ECGs gives us insight into the electrical activity of the heart, which helps diagnose different heart conditions. It is a strong, painless, and non-invasive method to check how the heart is doing. So how is it measured? So it is measured by electrodes. So electrodes on the body surface connecting to a recording device detect a small electrical changes from the cardiac muscle action potentials. So its components include P-wave, QRS complex, and T-wave. So the P-wave signifies atrial depolarization and precedes atrial contraction. The QRS complex represents ventricular depolarization preceding ventricular contraction, and the T-wave indicates ventricular repolarization preceding ventricular relaxation. Next are the time intervals. So the PQ interval, or PR interval, covers atrial contraction and the beginning of ventricular depolarization. And the QT interval spans ventricular depolarization to repolarization. Next is the limitations of ECG. ECG records electrical and not mechanical events in the heart. It can't measure the force of contraction or blood pressure directly. However, each ECG deflection correlates with subsequent mechanical events. Next is the diagnostic power. So ECG is a valuable, painless, and non-surgical tool for diagnosing cardiac abnormalities. It reveals abnormal heart rates, rhythm issues, conduction pathway problems, and identifies damaged cardiac muscle. So we use this table of abnormalities to help us identify conditions associated with abnormal heart rhythms.
So, in cardiac cycle, we have, in our heart, we have the atrium and the ventricle. So in the atrium, it is called the primer pump because it completes the filling of the ventricles with blood. Then our ventricle is the power pump because it produces the major force that causes blood to flow through the pulmonary and systemic circulations. So the cardiac cycle is a repetitive pumping process that begins with the onset of cardiac muscle contractions and ends with beginning of the next contraction. It is essential for maintaining blood flow and delivering oxygen and nutrients to the body's tissues. So the term cardiac cycle refers to the repetitive sequence of events that occurs during one complete heartbeat. It involves the contraction, which is the systole, and the relaxation, which is the diastole of the heart's chambers. So pressure changes produced within the heart chambers because of cardiac muscle contraction move blood from areas of higher pressure to the areas of lower pressure. And cardiac cycle is essential for maintaining blood flow and delivering oxygen and nutrients to the body's tissues.
So we are going to talk about the ECG. It consists of P wave, a QRS complex, and a T wave. Now, the P wave results from the depolarization of the atrial myocardium, and the beginning of the P wave precedes the onset of atrial contraction. So the QRS complex consists of the three individual waves, which is the Q, R, and S waves. The QRS complex results from the depolarization of the ventricles and the beginning of the QRS complex, which precedes the ventricles contractions. Now, the T wave represents the repolarization of the ventricles, and the beginning of the waves precedes ventricular relaxation. A wave representing repolarization of the atria cannot be seen because it occurs during the QRS complex. Now, the time between the beginning of the P and the beginning of the QRS complex is the PQ interval. It is also commonly called the PR interval because the Q wave is very small, as you can see on the picture. Now, during the PQ interval, the atria contract and begin to relax. At the end of the PQ interval, the ventricle begins to depolarize. The QT interval naman extends from the beginning of the QRS complex to the end of the P wave, and it represents the length of the time required for the ventricular depolarization and repolarization. Here we can see the abnormal heart rhythms. First, we have the condition tachycardia, which the symptoms are the heart rate is more than 10 beats per minute, and the possible cause is the elevated body temperature, excessive sympathetic stimulation, and toxic conditions. Next is the bradycardia. The symptoms is that the heart rate is less than 60 BPM, and the possible cause is increased stroke volume in athletes, excessive vagus nerve stimulation, a non-functional SA node, and a carotid sinus syndrome. For the sinus arrhythmia, the symptoms is that the heart rate varies as much as 5% during the respiration cycle and up to 30% during deep respiration. So the possible cause for this is it is not always known, and it is occasionally caused by ischemia, inflammation, or the cardiac failure. Next is the atrial flutter. The symptoms of this is that as many as 300 P waves per minute and 125 QRS complexes per minute, resulting in 2 or more 3 P waves, which is the atrial contractions for every QRS complex, which is the ventricular contractions. Now, the possible cause is the ectopic beats in the atria. For the atrial fibrillation, no P waves nor normal QRS and T waves, irregular timing, ventricles are constantly stimulated by atria, reduced ventricle filling, and increased chance of fibrillation. For the possible cause, it is an ectopic beats in the atria, which is the same as the atrial flutter. Now, for the ventricular tachycardia, it is frequently caused by fibrillation. For the possible cause, it is often associated with the damage to the AV node or the ventricular muscles. So it is important to note that the ECG is a record of electrical events of the heart and is not directly measurement of the mechanical events. However, each deflection in the ECG records indicates an electrical event within the heart and it correlates with the subsequent mechanical. And the analysis of an ECG can reveal abnormal heart rates or rhythms, wherein the problems in the conduction pathways, such as blockages, hypertrophy, or atrophy of portions of the heart, and approximate location of the damaged cardiac cycle. So often the ventricular systole is divided into two phases, the isovolumetric or same volume phase and the ventricular ejection phase. For the atrial systole, it refers to the contraction of two atria. Ventricular systole refers to the contraction of the two ventricles. For the atrial diastole, it refers to the relaxation of the two atria, and the ventricular diastole refers to the relaxation of the two ventricles. So when the terms systole and diastole are used alone, they refer to the ventricular contraction or the relaxation. The ventricles contain more cardiac muscle than the atria and produce a far greater pressures, which force the blood to circulate through the vessels of the body. During the cardiac cycle, it changes in chamber pressure and the opening and closing of the heart valves determine the direction of the blood movement, right? So as the cardiac cycle is described, it is important to focus on these pressure changes and the heart valve movements. So before we start, it is also important to have a clear image of the state of the heart. At the beginning of the cardiac cycle, the atria and the ventricles are relaxed. Now the AV valves are open and the semilunar valves are closed. So first, the blood returning to the heart first enters the atria. Since the AV valves are open, blood flows into the ventricles, filling them to approximately 70% of their volume. Now the atrial systole, the atria contract, forcing additional blood flow into the ventricles to complete their filling. The semilunar valves remain closed in here. Next is the ventricular systole. At the beginning of the ventricular systole, a contraction of ventricles pushes blood towards the atria, causing the AV valves to close as the pressure in the ventricles begin to increase. The fourth step is that as the ventricular systole continues, the increased pressure in the ventricles exceeds the pressure in the pulmonary trunk and aorta. The semilunar valves are forced open and the blood is ejected to the pulmonary trunk and aorta. Fifth is the ventricular diastole. At the beginning of the ventricular diastole, the pressure in the ventricles decreased below the pressure in the aorta and pulmonary trunk. So the semilunar valves close and prevents blood from flowing back into the ventricles. As the diastole continues, the pressure continues to decline in the ventricles until the atrial pressure are greater than the ventricular pressure. Then the AV valves open and the blood flows directly from the atria into the relaxed ventricle. So during the previous ventricular systole, The atrial were relaxed and blood collected in them. When the ventricles relax and the AV valves open, blood flows in the ventricles and they begin to fill again. So here we are going to discuss about the ECG. Again, here in the photo, the ECG indicates the electrical events that cause the atria and the ventricles to contract and relax. Now, the pressure graphs shows the pressure changes within the left atrium, which is the blue dashed line, as you can see in the photo, and the left ventricle, which is the black line, and the aorta dashed line resulting from the atrial and ventricular contraction, relaxation. The volume graphs represent changes in the left ventricular volume as blood flows into and out of the left ventricle because of the pressure changes. Now the sound graphs records the closing of the valves caused by the blood flows.
So to determine the heart sound, we use a stethoscope. So stato means the chest. It was developed to listen to the sounds of the lungs and the heart, and is now used to listen to other sounds of the body as well. These are the sites here on the diagram below. On the thorax, where the heart sounds can be best heard with a stethoscope. So the average heart beats approximately 75 times per minute. So the length of the cardiac cycle is normally about 0.8 seconds. So systole, which means heart contraction. Nice. Okay. So systole means heart contraction and diastole means heart relaxation. So there are two main heart sounds. The first heart sound can be represented by the syllable lub, and the second heart sound can be represented by dub. So ang ginatudo sa una, ang sounds ng heart is lub dub, lub dub, lub dub. So the first heart sound has a lower pitch than the second. So the first heart sound occurs at the beginning of ventricular systole and results from closure of the AV valves. The second heart sound occurs at the beginning of the ventricular diastole. So as I said, diastole is a relaxation and systole is contraction. So and it will result from the closure of the semilunar valves. The valves usually do not make sounds when they open. Okay. Next is ventricular systole occurs between the first and the second heart sound. Ventricular diastole occurs between the second heart sound and the first heart sound of the next beat because ventricular diastole lasts longer than the ventricular systole. So there is less time between the first and the second heart sounds than between the second heart sound and the first heart sound of the next beat. So, amo na dasig ang love dub, then may space tapos love dub. Wala siya. So, incompetent valve, which means when a heart valve does not close completely, which allow blood to flow in the reverse direction. So, it is when it leaks when they are supposed to be closed and allow blood to flow in the reverse direction. So the original flow of the bicuspid valve is from left atrium to the left ventricle. However, an incompetent bicuspid valve allows blood to flow from the left ventricle to the left atrium during ventricular systole. So this reduces the amount of the blood pumped into the aorta, and it also dramatically increases the blood pressure in the left atrium and the pulmonary veins during the ventricular systole. So during diastole or heart relaxation, the excess blood pumped into the atrium once again flows into the ventricle, along with the blood that normally flows from the lungs to the left atrium. Therefore, the volume of the blood entering the left ventricle is greater than normal. So the increased filling of the left ventricle gradually causes it to hypertrophy. And this will lead to heart failure. So the increased pressure in the pulmonary veins can cause edema in the lungs. So murmurs are considered as abnormal heart sounds and are results of faulty valves. So mabatian mo ni siya sa stethoscope. For example, is that incompetent valve fails to close tightly, so ang blood mag-leak through the valve when it is closed, making a swishing sound immediately after the valve closes. Another one is that incompetent AV valve produces a swishing sound also after the first heart sound. So when the opening of a valve is narrowed or stenosed, meaning narrowing, a swishing sound precedes closure of the stenosed valve. And another one is the bicuspid valve is stenosed or also narrowing. A swishing sound precedes the first heart sound.
So there are various measurements to measure or to assess the heart's function and the health. First is the stroke volume. It is the volume or the amount of blood pump per ventricle each time your heart contracts. Heart rate, common, is the number of times the heart contracts each minute. The cardiac output is the volume of blood pumped by either ventricle of the heart each minute. Basically, it is the product, or cardiac output is the product of stroke volume and heart rate. Cardiac output is important to be monitored for your clinicians to assess and manage a proper therapeutic interventions for you. And also, this helps your clinicians to assess the amount of blood that is transported in your body if there isn't enough or adequate oxygen that can be transported in your body. So this helps keep blood pressure at the levels needed to supply oxygen-rich blood to your brain and other vital organs. Cardiac output can be calculated by multiplying the stroke volume times the heart rate. Okay, so cardiac output in milliliter per minute equals to stroke volume in milliliter per bit multiplied to heart rate, which is beats per minute. Okay, so take for example, under resting conditions, the heart rate is approximately 72 beats per minute, and the stroke volume is approximately 70 milliliter per bit. Consequently, the cardiac output is slightly more than 5 liter per minute. So, paano nyo nakuha? Again, i-multiply nyo ang stroke volume, 70 ml per bit, multiplied to 72 beats per minute, which will have a product of 5,040 milliliter per minute, or converted to 5 liter per minute. So the control mechanisms that modify the stroke volume and your heart rate is classified, or there are mechanisms that could modify your stroke volume and your heart rate. And these are the intrinsic regulation of the heart and the extrinsic regulation of the heart. Intrinsic regulation of the heart, which will be discussed by Ms. Mendoza.
In the regulation of the heart's function, there are two main aspects to consider: the intrinsic regulation and the extrinsic regulation. So I will discuss first the intrinsic regulation. Intrinsic regulation is like the heart's built-in autopilot. It doesn't rely on external signals like nerves or hormones, but operates based on the heart's natural characteristics. This mechanism works whether the heart is in the body or kept outside under the right conditions. The intrinsic mechanisms of the preload and venous plane. Now imagine the heart as a balloon. The preload is like the stretch on the balloon's walls when it's being filled. This stretch determined by the amount of blood in the heart's ventricles, and it is crucial. The more blood the more the ventricle stretch. The more you inflate it, venous returns means more blood coming back to the heart, and this leads to a fuller heart, enhancing the preload. Next is the cardiac output. These stronger contractions result in more blood being pumped out. Increased cardiac output. This relationship is known as Starling's law. The afterload and its impact. Now imagine the heart is pumping against resistance. That's afterload. In hypertension, where there's increased pressure, the heart works harder against this resistance. And over time, this elevated afterload can strain the heart and lead to heart failure. The blood pressure influence. Conversely, lower blood pressure means less resistance for the heart, reducing afterload and decreasing the risk of a heart failure. In comparison to the preload, unlike preload, afterload has a more indirect impact on cardiac output. It's like the heart's resistance against an opposing force. And are overall impact on cardiac output. First, in the muscular activity, during exercise, when muscles are active, there's an increase in venous return. This boosts preload, stroke volume, and ultimately the cardiac output. And the second is the oxygen supply. This heightened cardiac output during exercise ensures that more energy is delivered to the working muscles. And understanding how preload, afterload, and their effects interplay is the key to grasping how the heart's intrinsic mechanisms regulates its function under different conditions, influencing overall cardiovascular health.
The next regulation is the extrinsic regulation, a mechanism that comes from the external of the heart. It could be nervous regulation or chemical regulation. Nervous regulation or baroreceptor reflex has two vital parts that are included, the baroreceptors and the cardioregulatory center. Baroreceptors are stretch receptors that monitor blood pressure in the aorta and in the wall of the internal carotid arteries, which carry blood to the brain. Changes in blood pressure result in changes in the stretch of the walls of these blood vessels, and changes also in the frequency of action potentials produced by the baroreceptors. Second is the cardioregulatory center, which controls the action potential frequency in sympathetic and parasympathetic nerve, extend from the brain and spinal cord to the heart. The cardioregulatory center also influences sympathetic stimulation in our adrenal gland. Okay. So as I mentioned, the nervous regulation or the baroreceptor reflex. Baroreceptor reflex is an involves autonomic nervous system which influences the pumping action of the heart and thereby affects cardiac outputs. Sympathetic and parasympathetic nerve fibers innervate the heart and have a major effect on the sinoatrial node. Since stimulation by sympathetic nerve fibers causes the heart rate and the stroke volume to increase. Sympathetic increases your stroke volume and your heart rate, whereas parasympathetic decreased your heart rate and your stroke volume. So here is the mechanism, or this image is the whole mechanism of baroreceptor reflex. So it begins in blood pressure, which is a Monian reactant. Your blood pressure, when there is an increase in your blood pressure, there is an homeostasis disturbance. And once that homeostasis is disturbed, The baroreceptors in the carotid arteries and the aorta will detect this increase of blood pressure, whilst the cardioregulatory center in the brain will regulate the sympathetic stimulation and will decrease the sympathetic stimulation of the heart, as well as in the adrenal medulla. And the next is it also increases the parasympathetic stimulation of the heart. In response to this, the regulation and the receptors, the sinoatrial node and the cardiac muscle decrease activity, as well as the heart rate and your stroke volume decreases. It is because napa-decrease mo ang sympathetic and napa-increase mo ang parasympathetic stimulation. And once this sinoatrial node and cardiac muscle decreases its activity, amo na ni ang pagbalik sa imo nga balance sa imo nga blood pressure, meaning you've already reached your normal range. So when your blood pressure decreases, it's like kabaliktaran ng managakalatawo dira. For example, the baroreceptors in the carotid arteries and the aorta detect a decrease in the blood pressure, then your cardioregulatory center will regulate the stimulation of sympathetic and parasympathetic stimulation, and the effect is that the sinoatrial node in the cardiac muscle increases activity and could increase also the heart rate and the stroke volume. Okay, so next, so remember that the baroreceptor reflex involve autonomic nervous system, parasympathetic nerve fibers, and sympathetic nerve fibers. The second is the chemical regulation, or what we call the chemoreceptor reflex. When we exercise or have emotional excitement, stress also influence the heart's function. This causes an epinephrine and small amount of norepinephrine to be released in your adrenal medulla. Once your epinephrine and norepinephrine will be released, it will bind to the receptor proteins in cardiac muscle, thus cause an increase in heart rate and stroke volume. The medulla oblongata of the brain also contains chemoreceptors that are sensitive to changes in pH and carbon dioxide levels. So if there is a decrease in pH or blood pH, it is because there is an increase of carbon dioxide in your blood. This results in sympathetic stimulation of the heart. Once yung nag-decrease na yung mga pH, your stimulation is active, or the sympathetic stimulation is active. So this is the mechanism, or the whole or complete mechanism of chemoreceptor reflex homeostasis. So earlier, nag-start kita sa blood pressure, or gina-detect ang blood pressure. This time, ang gina-detect naman niya sa receptors is the blood pH. So for example, if your blood pH increases, there is these chemoreceptors in the medulla oblongata will detect an increase in blood pH. Once again, this is because nag-decrease ang imo nga carbon dioxide. The control centers in the brain will decrease the stimulation of the heart and the adrenal medulla. So this effect that the sinoatrial node and your cardiac muscle decrease activity and heart rate, as well as your stroke volume, will decrease. So once decrease na, once your chemoreceptors, your control centers in our brain, decrease niya ang imong stroke volume, your heart rate, and your cardiac muscle activity, your blood pH will decrease. Mabalik siya sa imong normal range. So, for example naman, if your blood pH decreases, your chemoreceptors will detect that changes, and your control centers in the brain will regulate the stimulation of the heart and adrenal medulla, and this effect that sinoatrial node in your cardiac muscle will increase its activity as well as its heart rate and stroke volume. And nag-increase naman ng imo nga blood pH as the homeostasis is already restored. Okay, so this is the summary of extrinsic regulation. Sensory neurons carry action potentials from baroreceptors to the cardioregulatory center. The chemoreceptors in medulla oblongata influence the cardioregulatory center. Second is your cardioregulatory center controls the frequency of action potential in parasympathetic neurons extending to the heart. The parasympathetic neurons will decrease the heart rate. As I mentioned earlier, when sympathetic neurons in the work, there is an increase of heart rate. But if your parasympathetic neurons is working, there will be a decrease in your heart rate or your stroke. The frequency of action potentials in the sympathetic neurons extending to the heart. I mentioned ko na, the sympathetic neuron increase the heart rate and the stroke volume. The cardioregulatory center influence the frequency of action potentials in sympathetic neurons extending to your adrenal medulla. The sympathetic neurons increase the secretion of epinephrine and some norepinephrine into the general circulation. And this epinephrine and norepinephrine will cause an increase of your heart rate and stroke volume. So to summarize, when we speak of baroreceptor reflex, there is the involvement in autonomic nervous system with parasympathetic and sympathetic regulation. While in chemoreceptor reflex, there is an involved in secretion of norepinephrine and epinephrine. So this is the image or the photo that shows the what parts or what is this parts that has been part of the extrinsic regulation. Okay. Okay, so we are not in constant pace. Our body changes every time, every minute, every day, every week, every month, every year. And there are several factors that affect our health, body parts, the duration of our body parts. One of those is our age. Okay, at the age of 70, a person's cardiac output decreased by approximately 1/3. But by the age of 85, your cardiac output decreases by 30 to 60%. Okay, the next is the reserve strength, or when you already get older, let's say 70, 75, 80, 85, 90, your reserve strength of the heart decreases. This is the reason why some cannot react into blood loss. Mga delikado ang mga tigulang in terms of blood loss. May mga blood loss, hindi sila maka-respond sa emergencies, and budlay sila maka-respond, ang body nila maka-respond sa infections. Elders are also prone to hypertrophy or enlargement of left ventricle, coronary artery disease, and heart failure that commonly caused by the coronary artery disease, as well as connective tissue. When we get age, our connective tissue becomes less flexible, resulting in stenosis, semilunar valve, meaning wala na naga-flow normally ang aton nga blood. So, okay. So this speaks how important to include cardio exercises in our daily routine and daily activities. So I hope it was clear that our heart is innervate and intimately connected in our brain. That any neuronal impulses such as emotions just greatly influence our heart functions and health. Okay? As we experience, for example, if we experience strong emotions, our heart rate increases, our stroke volume increases, and then it is because our emotions, our neuronal impulses in our brain interact or connect into the heart. Okay, so that's it. Once again, we are the group 3. I, Cyril Alexi Gargoles Heredino, reporting. together with Ms. Cabrejas, Antolino, Mendoza, and Cadapos. Thank you for listening. I hope you learned something.